Good morning. My name is E.Czerwinski. I am Professor Emeritus of the Jagiellonian University and Senior Medical Director of Futuremeds. Welcome to Mo Academy. Today, a lecture will be on the basic diagnosis of osteoporosis. So right now, the lecture number 3 will be concentrated on the basic diagnostics, as mean interview, patient examination, densitometry, ultrasound, and differential diagnosis. And the fourth lecture will be on advanced diagnostics, like trabecular bone score, X-ray, morphometry, dexamorphometry, and QCTs. So we start with the patient interview, patient examination, bone densitometry, ultrasound test, additional test, and differential diagnosis. First of all, I don't like the word patient interview. I don't interview patient. Journalist does it. I chat with the patients. First, so we have to realize that patient want to be healthy and eventually happy even with the presence of the diseases. Words heal, really. Smile even better. Smile costs nothing but improves well-being of everybody. The question you should ask, first of all, whether she had any fracture. If she say no, it may be not the truth because she may don't know that she had a vertebral fracture. So we ask whether her height decreased. And we remember that 4 centimeter means fracture of the vertebra. Age of menopause and the eventual osteoporosis treatment. However, patient understand that taking vitamin D and calcium is the treatment. Patient age, of course, be polite. Women doesn't like this question. And whether her mother or family fracture, medical history, smoking, alcohol use, medication. And my secretary always informs patients to bring with them discharge summaries, test description, laboratory results, and imaging tests. This lecture is not is just for a beginner. So if you are doctors from a year, so skip that. And physical examination. First of all, I watch the patient when she enters the room. Is her gait, whether she was free or very, very uncertain, whether she needs help or sick, whether she is in pain. Then I walk how he sit down. Does she need support even more when he stands up? Whether he needs help. I watch her posture. Do they steep? Is down? Do they steep? Does the down come begin to start? There is general receipt, agile move, having generous condition, spine, curvature, physical comp. I always check handshake. And so I have information about the muscle, about muscle power, and also the length of life perspective, because people with the stronger handshake lives longer. So here is how the hump develops, and the ribs. It's painful. The ribs touches the rib of the pelvis. It is my patient. Oh, I treated her for 20 years. She is not coming now, and you see her lateral X-ray. Here are ribs, just supported on the pelvic rim, and this is really very, very painful. Want to diagnose osteoporosis, and we know the criterion, and we know the method, that the DEXA method is the right method. In 1984, definition is there is a systemic diseases characterized by low bone mass, deterioration of bone tissue, and susceptibility to fracture. So we can measure very precisely bone mass and estimate the BMD. Then we have, of course, the risk of fracture. So in 1984, this was considered that the T-score minus 2.2 standard deviation is the test and the threshold for osteoporosis. And this minus 2.5 was just chosen arbitrarily because 95% of patients who had the fracture got minus 2.5. The other is the osteoporotic fracture, is the low energy fracture. What is this low energy fracture? This is the fracture which occurs when it falls from the one ounce height. And if patients have 50 years and he trip on the pavement and fall down and fracture radius, she got osteoporosis. This is the proof of osteoporosis, and she doesn't need more measurement for osteoporosis. She had osteoporosis. Say again, low energy fracture in women over 50. This is the osteoporosis. And now about the densitometry, that's measuring the density and the principle of bone densitometry and dual energy bone the densitometry. What is the bone densitometry? Is the measuring of the specific gravity of bone. And we knew from the primary school that the specific gravity is the bone, D is the bone mass divided by bone volume. This is the 1 cubic centimeter. You see, that's very small, and you have to weigh that. If we weigh that, so we tell how is its specific gravity. We can measure that, but this we cannot measure, but we can estimate the volume. So in the Big method, this was also in the primary school. So we weigh that, what is the weight, and then we put it into the water, and the difference of the water level is the volume. So we can divide it and go to the specific gravity. I will start off talking of bone densitometry from the first method, which is not used but have been used in the past. I used the method in 1988, and it was so-called radiation absorption based on the normal X-ray. So we used a wedge for an aluminum wedge for a calibration, and this wedge got 1 centimeter here and half a millimeter steps. So here we have the optical density of bone, of soft tissue, and air. And here is my hand with this wedge. And then we compare to which thickness of aluminum relates the optical density of this wedge. Say it could be 3 millimeters of aluminum. That means the optical density is 3 milligram of aluminum. Why aluminum? Because the atomic mass of aluminum is very close to bone, 29 versus 27. And this aluminum wedge or different, but aluminum is used for calibration. Every DEXA machine and QCT machine. Now, here is but the next method is using the X-rays measurement with the detector. The first was not X-ray by the radioisotope source. And here it is the source, it is the detector, and then we measure the bone density. Again, have to be calibrated with the aluminum wedge. But it was easy if you have a nude bone without soft tissue, but in real life, women have soft tissues as well. So to eliminate the soft tissue, the first DTX single X-ray absorptiometry use the water. That means if we put a limb in the water, so the density of the soft tissue like the water, so we measure like it would be on water only. And this was the first densitometry I used this was the first densitometer I used in Krakow in 1994. I hired from the Professor Lawrence 1994 years, and we did in 2 years 40,000 of measurements free of charge. So we can put a limit the water, but unfortunately, and we can make they have a like women, we can't her they weight, so we have her weight, but having a mass would be difficult. We have to put the in the basket. So we could fill up the tube, water tube, the bathroom tube, and put the lady and measure the water, but I don't think any patient will like it. It will be very, very difficult to perform. So we came to the principles of the dual energy absorptiometry, and then I will describe it. Next slide. So here is the dual energy absorptiometry, and it based of the absorption of soft tissues and bone in low energy and in high energy. That's why we call it dual energy. So if we have this phantom with low energy it means 30 to 50 kV, we got such a curve, a soft tissue, bone, soft tissue, air. But if we put it to high energy in red, you see the change. It is the change in the soft tissue. It is the change in bones. So you see the change of the density of the related measurement of bone in high energy changes much more for bone than for soft tissue. And this is the basis of calculation the density without putting patient in the bathroom tube. So it is dual energy absorptiometry. Those equipment varies, but the result, but the method is exactly like I told you. Here you have the contemporary DEXA machines. It is a positionary for the lumbar spine and for the hip. And you see here is the X-ray source, micro X-ray source, which emits a high energy and low energy voltage radiation. And here is the detector. That's a positionary for the lumbar spine, and here is for the hip. I will talk more later about kinds of these machines, and at least we got the results. So here is the image. It is not for diagnostic purposes. This image is just showing us about the area of measurements. And this is another lecture about the region of interest. Here is the neck, here is the trochanter, and that's the total. And we got the results. We got the results. A BMD square centimeter square. I will explain later why it is not cubic, but square, because they are not cubic. We have it okay, another lecture. The next lecture. I mean, and we have density of the neck is here, 0.53 grams per square centimeter trochanter and total. And if you will tell patients or yourself, is it right or bad? You don't know. So we have to compare that result to a norm. What was the norm? The norm is in where peak bone mass 35, 40, and we relate either to the age of the patient, the same group, or to peak bone mass. I will tell you later. And you have two indicators. One is the T-score. So this, if you compare to the peak bone mass, is minus 2.1, 2.9 T-scores, and Z score is for the age. So we want to compare the true patient measured to the control group. And first we can compare to the age group similar to those investigated. So here we have patient 60 and control group 60 years old. And here we have a standard deviation. Like in Gauss curve is the 0 and standard deviation plus or minus. So this worth of the measure compared to the control gives us 1.1 standard deviation difference to the age group. That means Z score. And here is a T-score, means comparison to the peak bone mass. Why we use the T-score? T-score tells us how much the patient lost. So how big is her fracture risk? And of course, this is why it was taken to the FRAX measurement and this magic minus 2.5 as a threshold for osteoporosis. So here we have the printout of from our machine. This image is not for diagnostic, I repeat, it's just for checking whether the technician did a good job. And here we have the BMD. We take neck or total, never take wards, and somebody takes trochanter. And you have the diagnostic criteria I told the first lecture of WHO, still the same. Osteoporosis minus 2.5, osteopenia up to -1, norm +1 plus 1, and severe osteoporosis -2.5 plus a fracture. We experience the peripheral densitometers. This is the DEXA densitometer, and this is the ultrasound densitometer, quantitative ultrasounds. They are very, very popular, they're very cheap and very easy to handle. You can tell your rears of your back you can take your rears of your car, and they measure speed of sound. That means is acoustic measurement, like ultrasound or attenuation, and got also T-score and G-scores, but cannot be used for diagnosis for osteoporosis. And just be correct. These measurements are not for diagnosis. They can be used for the screening. Location of the measurement. Here you have a WHO location, and this patient got on her spine minus 3.2, her forearm minus 1, and the hip minus 1.5. That's it. And we take the lowest. The lowest, we need at least two measure vertebrae, and we have always average. We take average. So we say this lady has osteoporosis quite advanced. And she may go to the QCT, got minus 0.1 very well. She may have from the distal radius, she may have forearm QCT, and may have ultrasounds. So she got a lot of measurement. So she asks whether she is healthy or whether she is sick. So solve this forever. We have a position statement of WHO, IOF, and OF. That the standard is the DEXA method of measuring bone density. The primary measurements are just proximal femur and spine, and diagnosis of osteoporosis cannot be used on images obtained by other devices or other reference size. And this is still obligation nowadays. Now we will talk more about the principles of bone densitometry, especially dual energy, DEXA, and how to interpret the results. So here's the printout. Here we have a patient data and date of measurement and or measurement of lumbar spine. What's very important that at least two vertebrae have to be eligible for measurement, and we are always taking the average. And patients are sometimes confused because in this case, in this L1 have no osteoporosis and severe in L3 average, so we are always taking average. And T-score is adequate to take into consideration if patient is over 40. Below that, we take about Z-scores. Okay, so, and now proximal femur, and we have neck measurement is that area, and there are some small differences between lunar and hologic. Technician have to know that. And so here is the neck, here is the trochanter, and that's the total. FRAX takes into consideration the neck. US likes total. In fact, they are usually different, but the practical meaning is absolutely the same. The best way is to take two into consideration. In my everyday practice, I care about the neck because neck is in the FRAX measurement. The more important measure is the hip, and in primary assessment, it should be the diagnosis of osteoporosis, not spine, because the more important in osteoporosis is the proximal femur fracture. So we use the lowest level of 3 neck total trochanter. In fact, as I told, neck or total. Advantage is that the measurement in the proximal femur is the best determination of the hip fracture, and decline of one standard deviation give increase of the risk 2.6, almost 3 times That means if you have T-score -1, no, -2, and then -3, that means the fracture risk increases 2.6 times. It is standard measurement for the risk of fracture, and measurements are stable in all ages. Adventure of spine, because spine is built mostly of the trabecular bone, have a quick metabolism, so we have the earliest signs of osteoporosis and also earliest signs of treatment effect. Is good therapy effect, good clinical criteria, but unfortunately, we got since 50, we have degenerative changes, osteophytes with artificially improved bone density. So here we have a patient, female, 50 years old, and her spine is -2.4. And here is a lady, 80 years old, and her results are better because she got a loss of osteophytes. So that's you have to take into consideration. In fact, results of the spine over the 75 are really questionable. And in this case, here you have the X-ray, and you see how advanced osteoarthritis, spondyloarthritis is advanced. So this result could be misleading. Whereas always take spine and neck, because spine gives that early changes and response, and neck we have a permanent results over patient aging. Do it annually. Use the same manufacturer because they are different. I will tell you later. And if you have two manufacturer, just compare T-scores. And differences result from the different use of high-low energy, different aluminum hydroxide patterns, different phantoms, and different control groups. So this is why we cannot compare directly BMDs from, say, lunar hologic or Norland. Again, in that situation, we can compare the T-score. Follow-up examination, we do yearly. This one of my patient, 13 years. First of all, every laboratory should have the lower significant change, and it is all about 1, even 5%. So take into consideration that there is a machine error about 3% roughly. So here we have a printout of measurement from 2010 to 2023, and changes of T-scores, changes of BMDs, and here is the comparison of the BMD baseline, and here you have the level, and so there's the BMD in 2010, 2023, and we just calculate the percentage, and the percentage is just 23. And usually what is important is compared to the baseline, how it is, and to the previous. If you have such striking results that patient lost 7% and here gained 5%, so there is the manufacturer error. And be careful because there is no way that patient one year lost 7%, the next year give 10%. No way. It is the machine error. So this is very safe method. The radiation is meaningful, really. And just if you compare the daily background, we go from the space is per day 5 to 8 microsievert. chest, give 50 to 150 microsivia, mammography 400, lumbar spine of X-ray even 700, and VFA, vertebral fracture assessment or later 2 to 4. And you have the pencil beam go lowest, 0.5, and fan beam a little bit higher, but it is still very low. So if patient asks me about the exposure, I say them that per hour we are giving 0.3 microsivia. So for if you are outdoor 1 to 2 hours, you got the radiation of pencil beam and 6 hours for fan beam. However, there is a general rule in all medicine, and not only alarm can be as low as reasonably practical, but this is absolutely obligatory in any using of X-rays radiations. Now, this is the old machine, but still existing as a second hand. Pencil beam have just one X-ray, will measure the body, and here is the fan beam. Another machine, that's the lunar, that's the hologic, and we have many detectors, and if you compare, sensitivity is just the same. Fan beam is much more higher, it's quicker, much more clear, the short measurement, but the true difference of time consuming is the patient positioning and the striking, but total body takes 20 minutes in fan beam and say 5 minutes or less in the fan beam. We can do spinal morphometry, we do TBSs, and fan beam also body composition is quicker, a measurement orthopedics. Unfortunately, they are much more expensive, and these machines are really expensive. I think more than they should be. Now we turn to the ultrasound measurements, and first of all of you are familiar with ultrasounds measurement general medicine. This is a prenatal image. And the image is produced like there is a probe which emits the sound, ultrasound, and measure the reflex and create the image like that. In US, in the ultrasound used in osteoporosis, we are measuring transmission. That we are measuring the change of the sound wave when he passed through to the body. And the quite new using sort of the spectral analysis, so they measure the reflex of the ultrasounds to the probe. So here is the measurement of the osteoporosis. We have transmitter and the receiver, and we measure and have to be either the water or gel, because it will be some space different from the body. It will be a reflection, and we are measuring, so that is sound, and we are measuring time, that's speed of sound, and we measure the BOH, bone attenuation, and perceive the stiffness index. So this is the healthy and osteoporotic. As I told you, they are very cheap. They foresee the fracture, in fact, but it is not accepted for osteoporosis, and only the here gives some constant results. That's a new from a couple years backwards. It is called RIMS, radio frequency echographic multispectrometry, This is the equipment, and it measures the reflection of ultrasounds. That's the wave, and it does calculates the BMDs and gives a very comparative results to the DEXA, and also calculates this score and this score, and for SE, this for spine, is easier to perform, is transportable, and no radiation, is no sensitive to the degenerative changes, and also they also include the FRAX measurement. And as you see here is the DEXA measurement this is not sensitive either to spondyloarthritis, spondylosis, and either to fracture and be cemented, because you go for the from the surface. If you compare DEXA at rims in the fracture prediction, so here you have 500 women with follow-up 3.5 years, 70 fracture, and the fragility score gives even the best result as the producer claims. Here we have the orange is the DEXA, the T-score, and is the fragility score. So you see that the specificity is quite high. It reaches even reaches. If we have a patient with a low BMD, I mean below the 2.5, we have to make differentiate diagnosis. Why? Whether it is simply postmenopause osteoporosis or secondary osteoporosis or some other issues. So we have to do additional tests. And the first year is CRP, morphology, calcium, phosphate, creatinine, alkaline phosphatase, vitamin D, urine analysis. That's the first year. The second will be PTH, TSH, electrophoresis, ASPAT, and on the very end, bone markers. I am very skeptical of bone markers. I don't use them in everyday practice because the results are so not meaningful, but it is standard of clinical trials, and always do one of the bone forming markers, like bone phosphatase, and bone resorption marker, CT telepeptide. It would need another lecture to discuss the diagnostic criteria. The sedimation rate is raised in multiple myeloma, very low, and HB is low. Low calcium is absorption disorders, vitamin deficiency, and osteomalacia. Increased calcium, be aware. Neoplastic diseases, primary hyperparathyroidism, low phosphorus in osteomalacia, and so on. This is the very good study of Professor Marcinoska. Okay. So we came to the conclusions. DEXA is the standard of measuring bone density for diagnosis osteoporosis, and the reference sites are proximal femur and lumbar spine, and do always both of them. The densitometric measurement done with another method and other size are not equivalent and cannot be to the diagnosis of osteoporosis. The goal of osteoporosis is to determine the fracture. According to the criteria, the threshold from diagnosis is minus 2.5 T-score, and decrease of BMD requires differential diagnosis. Decreased BMD indicates really the increase of fracture risk, especially in the hip. One standard deviation means increased risk 2.6. but normal BMD doesn't rule out the risk because 70% of fractures occur in patients who do not meet criteria WOH. Please don't forget it. A standard of measurement is spine and hip, and proximal, and measuring the proximal femur, the best predicts the fracture risk in this location. The advantage of spine is that the changes are very early and in response to medication immediately, but unfortunately, with aging, degenerative changes occurs and just mismatch the results. The practice, the proximal femur is not much inflated, but there really changes. A measurement of the neck is the basis calculation for FRAX. US likes the total, Europe likes the neck. In fact, it doesn't matter. These results are absolutely the same. Quantitative ultrasounds can be used only in screening, then foresee the fracture risk, but are not accepted for diagnosis of osteoporosis. RIMS, radiofrequency echographic multispectrometry, produce results which correlate very, very well BMD and predicts fracture risk. It can be used in diagnosis, but is not accepted so far by WHO and IOF. However, this is in progress. Saying that, I wish to thank everybody for your attention, the time you spent with me. I would invite you to the next meeting, and this was the third lecture. You can have 9 more, and I would appreciate your remarks, question. Take care, and bye-bye.